Hello.
Hello, good evening, sir.
Good evening. Good evening. I think so. Mehul, your name is Mehul, na?
Yes.
Mehul, I think so. Last time we can just because Smriti will start and then we can start the little face support, right? She will say something and we can start. So you can make a live. We are ready now. Huh?
Okay. So we'll start.
Yes.
Okay. So good evening, delegates. So Wings Fertility Conclave Series 2. So which is initiated by the Wings Women Hospital and IVF Center and supported by the Corona Remedies Private Limited on the topic of luteal phase support in infertility. Okay. So we have an expert speaker and we will get a guidance from our expert speaker, Dr. Jay Shamin and Dr. Smriti Sparsh. So first of all, I welcome Dr. Smriti Sparsh. So I will say that Dr. Smriti Sparsh is a chief consultant in Wings IVF Patna, and earlier she was an assistant professor in Netaji Subhash Chandra Medical College and Hospital, Bihta, and also she was a joint secretary in Boxcon 2022. So Dr. Smriti Sparsh is a keen expert in infertility and laparoscopy, and she was awarded with a CL Jhaveri Award and Times Youth Icon Award, and also Ishar Youth Icon Award in 2023. And currently she is a member of FOXI, IFS, IMA, Ishar and BOGS also. So it's my pleasure to introduce you, and I welcome Dr. Smriti Sparsh and hand over the session to you.
Thank you, Mehulji. Thank you, Corona Remedies. And indeed, it is also my pleasure and privilege to introduce our clinical director, Wings IVF Group, also the Secretary Gujarat chapter for the Indian Fertility Society, Dr. Jayesh Amin. Sir is a national and an international faculty at various fertility conferences in India and abroad, has also been awarded as the Times of India IVF icon for the year 2018 and 2019, with excellence in the infertility treatments by the then Union Health Minister, Sri J.P. Nadda ji. He was also, by the Economic Times in 2019, awarded as the Fertility Game Changer West. With many contributions in the field of infertility, Sir, to his credit, has multiple achievements. Just to mention a couple would be live birth through IVF in the last 8 years, 12,000 plus and still counting, with 8,000 plus successful stories to tell in cases of recurrent IVF failure. The main focuses of interest that Dr. Jayesh Amin sir holds includes troubleshooting complex infertility, recurrent IVF failure cases, application of the latest technologies in the field of IVF, and the role of genetics in IVF treatment. We welcome you, sir, and are also eager to hear your talk.
Thank you so much, Smriti. Welcome, Smriti, on this. Our goal basically is only that we are interested specifically the people, those who are the new generations. Yes. The new ये मुझे करना है, बाकी मुझे अभी सेव रखनी है. ठीक, हाँ. The new generation, those who can get the knowledge regarding the IVF treatments, and I think so it's a sharing a knowledge to my colleagues. It's life is always learning, and it's all my sharing my experience and my experience, and especially luteal phase support in ART is basically a most most important topic. Basically, it's all because you have done everything, and now still Cochrane data is not decided that what is exactly luteal phase support is required, especially in the freeze embryo transfer. So today's we are going to discuss from phase cycle to the frozen cycle transfers. what is evidence and what is exactly we are doing. And I think so we are concluded now. We are happy to conclude it now. The query which is people are discussing that injectable or the vaginal progesterones, what is it? So we have our own publication which is coming and we have our own data. So I will start luteal phase supports in ART. Just 2 minutes. My lecture is just my slides are sharing. Yes, Charlie. Sorry for technical fault. It's not still not. Okay. So let me tell you something. At present, I'm not sharing the post of Gujarat IFS secretary. At present, I am a joint joint secretary to the central IFS. And another thing is that let's start something, a topic that luteal phase support. So the most important part that less logically we can ask one question: what is luteal phase? And as far as concerned the luteal phase, I think so we all people are in the our residency, we are knowing that it is a period of around 14 to 16 days and after LS surge, and which is predominated by the hormone which is called as a progesterone. Progesterone is a Greek word. Pro, that means pre-geston, means pregnancy. It's a pre-pregnancy hormone. So it is dominated by the progesterone and also estrogen. And because it's all events is because they're responsible by the luteinizing hormone, that is LH is responsible. So our second question, I am always saying in my lecture, and I always believe that this is a one hormone. The knowledge of one hormone is so crucial as far as concerned the being an IVF expert, that is called LH. And that's why LH is always crucial everywhere, whether it is recruitment, whether it is quality of the oocyte, whether it is disturbed quality of the oocyte, and let's on say something about the implantation milieu, that is called LH is most important for the progesterone secretions. It's crucial because it's a receptor which was on the corpus luteum. And because of that, we know that because of the CMP pathway, it is going to be secrete more and more steroids. It is also responsible by all the effect of the LH and the progesterone, which is responsible for the upregulation for the implantation factors. Say, for example, it is a growth factor or VEGF or FGF. And it is also responsible for the whole milieu which is occurred for the cytokines, and the implantations event will be there. The certain points we know that are the facts of the progesterone. The facts of the progesterone, that where it is effect. So out of that, whatever the slide shows, the two important part today's we are discussing in the 2023 is the immunomodulating system, which is more important to prevent the loss and the shifting from TH1 to TH2, which is responsible for the acceptance of the pregnancy inside the uterine cavity. And second most important part, that decrease the contractility, which is again favor the implantation. These two things are so important, especially in the ART pregnancy concern. Progesterone, what is the history of progesterone? I already say it's a pre-pregnancy hormone. And I think so it's in the 1972 in America, there is a act which is the Medical Termination Pregnancy Act, which is prohibited to termination of the pregnancy, where people are doing the triple ligations and accidental finding of the pregnancy. Sometimes gynecologists doing the destruction of the corpus luteum, and that they show something after destruction, there is a loss of the pregnancy. So by that we can come to know that there is a role of something corpus luteum, and the hormone which was secreted by the corpus luteum is the main progesterone. And when it was added by the progesterone, there will be a continuation of the pregnancy. So we can understand what is the role of the progesterone in the maintenance of the pregnancy. What will be the history? Let's say something about luteal phase defect. So ultimately, we are talking about that. Is there any physiological defect where it produces less progesterone? And if I say a less progesterone, then it will be an imperfect corporal lutea. And if I say it's an imperfect corporal lutea, then it means it's related to disordered folliculogenesis. And if I say something disordered folliculogenesis, I can say something about something defect in the hypothalamo-pituitary ovarian axis. And if I say something about hypothalamo-pituitary ovarian axis, the hormone may be hypothyroidism, the hormone may be hypoprolactinemia, which is responsible. And the other part, which all are the axis, which is basically so sensitive, and the sensitivity is depending on the weight loss, that means your nutrition, and it is depending on the stress. And these all are going to disturb your HPO axis, which in turn leads to a follicular disordered folliculogenesis, and you can have a corpus luteum, disordered corpus luteum functions and luteal phase defect. What about the physiology, especially in the stimulated cycle? Look, you are stimulating the ovary when with the gonadotropin, and if you are stimulating the ovary, the follicle is going to be mature earlier compared to the natural cycle, and that is going to be reduced. So hyperstimulated cycle will have an early growth, and that's why the length of the luteal phase will be reduced. So we require certain support. So this is the first thing that what we can say why it is required. Now let's talk about the why it is required in the ART cycle. And if I ask about the ART cycle, then it's all about the supraphysiological E2 and progesterone. So if we have a supraphysiological E2 and progesterone, because of the negative feedback mechanism, there will be a less LH. And if there is a less LH, again, improper corpus luteum function, right, which in leads to a less progesterone. So we can say something, the supraphysiological level of the estradiol, which is in turn responsible for the luteal phase defect in the stimulated cycle of the ART. So now this is a burning question that let's find out that how to diagnose of this luteal phase defect. Can we diagnose in the era in the year of 2023? What will be the evidence? Previously in the history, when we learned to in our history part, we say something about if the short cycle, yes, this is something which we can consider they might have a less progesterone. So luteal phase defect will be there. If there is an intermenstrual, so in the luteal phase, early luteal phase bleeding will be there, then we can also consider she might have a luteal phase defect or she might have a polyp, right? So these are the two conditions where we can consider by the history. I still not believe by this evidence that 8.1% of the populations do have they have a luteal phase defect. I still not consider. So I will consider there is a very small percentage in the fertility they do have a luteal phase defect. Now that is the era, there is a paradigm of the history because of the development of the CIA technology of the progesterone. So let's measure the progesterone, and the second publication, the paradigm which is to diagnose the luteal phase defect was serum progesterone. And it say on the 21st, the mid cycle of the luteal phase, if it is less than 10 nanogram, then we can say it's a luteal phase defect. But I think so, when we measure the progesterone is the pulsatile release. And if we measure in the morning, it will be maybe something different. And it maybe we are measuring in the afternoon, and in the evening, then it is something different. So because of the timing of the progesterone and the peak value, maybe at the time of the measurement of the 3 value, we might end up with the wrong diagnosis. And the fourth part that I can say something, because of that, the progesterone will be not considered as a diagnosis. So this is a paradigm where people do consider before sonography to measurement of the progesterone. Then I think so it was well covered before that, and I think so before, or it's a journey with hands on hand or serum progesterone with the histological dating of the menstrual cycle. I had seen something my so many senior to measure the doing the DNC and the confirmation of the ovulations, and especially for the progesterone. But I think so this is a very crude method, and nowadays it has been replaced by the ovulations study by the sonography, and we can also see the progesterone primed endometrium and the colored blood flow, which can indicate that is it a progesterone is sufficient during the ovulations or not. So looking to all the paradigm from estimations of the serum progesterone to sonography and the histopathology, which is a very invasive method, what is exactly we can know about the luteal phase defect? Can we diagnose luteal phase defect? Do you have any reproducible tool? And the answer is no, there is no. So there is no any reproducible tool to diagnose the luteal phase defect. And still that's why we are giving a progesterone, because more is not harmful. We are giving progesterone when we are feeling, especially in the infertility, pregnancy loss, and the very precious pregnancy and the ART pregnancy. So let's see something, what are the evidence to give the progesterone in the different part. Because of that, before the discussion of that, this is one of the physiological tools that what I want to discuss with you is that in a natural cycle, if we see something about the luteoplacental shift, and this is more important because the corpus luteum, which is taken over by the primitive placenta, and that is occurred especially around 9 to 10 week. And that is why this is the way that if the 9 to 10 week, if there is a good shape, there is a placenta is shifted, I think so this is the time in the natural pregnancy, in the presence of corpus luteum, we can stop the progesterone. So this is the one physiology that I want to inform you before to start something about the luteal phase support. Now let's say something about the practically what I don't want to go by theoretically, but then say something luteal phase support in a IUI stimulated cycle, what is evidence? And let's say something about the meta-analysis which was published, and this meta-analysis which was assessing the IUI cycle, which is stimulated by the clomiphene citrate, letrozole, and as well the gonadotrophin. So at the end of the day, the conclusion was very clear that in clomiphene citrate induced cycle, there is no requirement of the progesterone. So luteal phase support is not required. Maybe LH value is very high in the CC induced cycle, which in turn support, and that's why the progesterone is not required. But should we not give the progesterone? Should we are practicing like that? No. And that is what I say, that as progesterone is still not harmful, people are still giving, but the evidence is against that CC induced IUI cycle, there is no requirement of the progesterone. As far as concerned the gonadotrophin, they say that because of the stimulated cycle, electrolytic effect, shortened luteal phase, and hypersteroidogenesis, these all are in favor to give progesterone in IUI cycle. So it is very clear that by the two meta-analysis which was published in a different way, they are very clear that the luteal phase supports in IUI is only required in the stimulated cycle in gonadotrophin. It is not required in CC-induced IUI cycle. Now, way back, I want to go way back when we are doing about the phase cycle transfer. Let me inform that I haven't transferred from 2014 any phase cycle transfers, but I am just recollecting my memory that what about the progesterone which available when we are doing a phase cycle transfer. And I know that we started the practice with the IM progesterone. There is a paradigm of IM progesterone. And before that, I think so, the SCG people are using, and then there is IM progesterone, and there is introductions of the vaginal progesterone and also the oral progesterone. So these are the 4 progesterone support which is available during the phase cycle transfer. I want to inform you that the first all slides are related to stimulated cycle, because still 30 to 40% of the cycle in India people are doing in a phase cycle transfer. So this is the evidence and this is the answer, that 3 randomized controlled trial and 1 meta-analysis, and it is include more than 2000 cycles, that vaginal is more safer and equivalent effective to IM and oral. Less side effect, no pain. And that is why the paradigm of the shifting from SCG, which is producing more OHSS, and when people are shifted to IM, which is more painful, because of this evidence, people shifted toward the vaginal. Maybe it is whatever the formulation will be there, but people shifted toward the less side effect vaginal progesterone, micronized progesterone. Now, when we talk about the vaginal micronized progesterone, there is a lot of development. And because all this development, they have a different part of the vaginal progesterone, different type of the vaginal progesterone, but it doesn't make any significance. So if the gel people are saying that it's only comfortability, but pregnancy rates are not going to differ whether you are using a pessary, though the pessary is cheaper. So if you are dealing with the low socioeconomic class, and I think so people are very comfortable with the pessary because of the development, I think so pessary might be one of the choice compared to the gel. Though I am using gel in my practice, it's all about the compliance and which type of the populations you are using, that is more important. But scientifically, the same clinical pregnancy rate. Let's say something about the evidence of the IM progesterone, and it is totally against. So IM progesterone is equally important, equally giving same pregnancy rate. It is about 50 to 100 milligrams. Especially I'm talking about the fresh cycle transfer compared to the pessaries and gel. So now the Cochrane data. Let's conclude the Cochrane data in luteal phase supports in ART cycle, and especially in the stimulated cycle. There are study of the 16 randomized controlled trial when there is a paradigm of SCG and there is a launch of the micronized vaginal progesterone, and the message was very clear. The message was clear like that progesterone is equally effective. Not it is equally effective, but it is producing no OHSS. And that is why people are shifted in the normal responder, high normal responder, and the PCOS patients, hyper responder, people are shifted toward the progesterone, the micronized vaginal progesterone. I do agree that you can use SCG as an alternative, especially on the poor responder. But I still see the trend toward is we all are shifted toward the micronized vaginal progesterone, specifically in the luteal phase support in the stimulated cycle. Now, that is what the publications way back when we are talking about the oral progesterone. And why we are thinking about the oral progesterone, it's all about the patient compliance. It's all about the tolerability. And the issue was that this is a new molecule where they are claiming that it is reducing abortions because it is the only one progesterone which is responsible for the immunomodulations. And looking to that, this is our own Dr. Baidyanath Chakravarti, the publications, and the publication is very clear. They say that it's a good tolerability. Dydrogesterone will having a patient woman satisfied. Its oral is always best with the tolerability treatment. But if you ask me that it is also reducing the abortion, but the study size is very small. If you see that the dydrogesterone is 79, and because of that, the study was not accepted. And the other part is there are something which is going on in the European part, that dydrogesterone, some retrospective data in the African population, it is having some effect on the cardiovascular abnormalities. And because of that, there is no data, and people are making more safe, and it was not used in the part of the America and on the Europe. But I know that the Indian people are always telling that there is no side effect. And we people are using the progesterone, specifically our gynecologists are using very much higher in the threatened abortion miscarriage. And that is why before that, this molecule is very well known in our Asian perspective. But later on in 2015, 2016, George Grisinger, the phase 2 randomized control trial. And what is it? And they find out they have a double-blind, randomized control trial where they can have a 497 patients, which they put on the oral dydrogesterone and the micronized vaginal progesterone, so almost 1,000 patients. So until this publication, we don't have any use publications on the dydrogesterone and micronized vaginal progesterone. The oral dydrogesterone, which was used 10 milligram 1 TDS, and micronized vaginal progesterone, they use 200 milligram 3 times a day vagina. Now, they concluded that they include the ongoing pregnancy rates, 12-week pregnancy, and also they discuss about the live birth rate. There will be no discuss of the clinical pregnancy rates in this study. The bias of this study is that if you see the Caucasian populations is 97.6. So there was a missing of African populations and Asian populations. And what will be the conclusion? Conclusion is something we it is not acceptable, or we can say something is acceptable, but how can we replace? There will be a lot of questions in the clinicians that are we doing something wrong previously or what? But conclusion is very clear that at the end of the day, that micronized vaginal progesterone, the ongoing pregnancy rate, the oral dydrogesterone is out of 100, the 4 live birth rate is higher than the micronized vaginal progesterone. The 4% higher rate compared to the 33, means compared to the microvaginal progesterone. So looking to that study, it was now we can have one more option because it's a bias that it was used in a populations where Caucasian, so there will be something which is multi-centered study, and it was used only on the pessaries, so they can say something about the gel. These are something a side effect which was common in both, and the second part of the Lotus study which was published in 2018, and let's say it's an RCT and it is a multi-centric trial, and the answer is very clear. Answer is that both success rate are same, the live birth rate are same. And looking to all this study, we have a 2 paradigm. So previously we can start the paradigm of SCG, which was shifted because of the OHSS to the micronized vaginal progesterone. And 2015 to 2023, we have a third paradigm of the availability of the progesterone with the oral dydrogesterone, which will be more tolerable because it will be administered orally. So we can have one options to counsel the patients when the results are the same. Now, this is what about the 3 hormone, that is what we are using. And in stimulated cycle, we all are skipped the IM progesterone. Now, what is the dose of progesterone? Is there any idea of progesterone, how it is decided? Because I have a same question in Lotus, that why not 20, why not why 30? And this was not answered. And that is why the study is still lacking on the dose. There is a lot of debate on the dose, that how it is decided. But at the end of the day, this article is suggesting that if you are using a micronized vaginal progesterone, then it will be around 600 milligram in a divided dose, 600 to 800 milligram in the divided dose. As specialists in the European country, the standard practice, the half-life is 8 to 10 hours. People are using TDS, 200 milligram every 8 hourly of the progesterone half-life. Now, the second part is when to start progesterone. So the most important answer when we say something starting, you should aware that not on the day of SCG. If you add progesterone on the day of SCG, you will have a 2 days more progesterone. And if you are giving more than 2 days progesterone, it will advance the endometrium and the pregnancy rates are so low. So what will be the starting dose on the day of IUI or on the day of OPU, on the day of procedure? Now, let me tell you something. In the stimulated cycle, even 1 day late will be not going to be much more effective in reducing the pregnancy rate, because we have already existing corpus luteum. So I used to say something, it is what we are getting something more adjuvants. Whatever the progesterone we are adding, which are add-on, might be it is something it is lacking, so we are add-on. So even 1 day later, giving progesterone, which is not going to be detrimental for the cycle of the phase cycle transfer. The question which was always debatable, and whatever the speaker will speak, but we all people are saying that more is not harmful. So there are different studies which say that by this meta-analysis, let's stop immediately. So it will be not, it's all about the money which was spent by and the body where they are putting the pastries and everything. It is basically having a certain side effect. So because of that in mind, we are discussing that let's stop as early as possible to reduce the expenditure of the money, which is unnecessary. The stimulated cycle, the idea, the publications was very clear. They said we can immediately stop after beta SCD positive. And the second study, which was published by the Giovanni Velasco in 2012, because there is no randomized controlled trial to produce the support that how earliest we can stop. And the second study is you can stop at 5 week gestation. And I think so, conventionally, it is accepted in a stimulated cycle, you can stop when there is a uteroplacental shift, a luteoplacental shift, and that is around 8 to 9 weeks. But instead of this, all publications, people are giving 11 to 12 weeks all the progesterone. When we are talking about the stimulated cycle, then we are a very much debatable point, which was a co-treatment. And I think so, until now, I think so, there is no co-treatment in a stimulated cycle was effective. Say for it will be a estrogen. There are 2 studies, which is one agonist favor. There is second study in antagonist not in favor. So this issue is open. Debate is open. The floor is open, but still, I think so. I will like to give my opinion that in stimulated cycle, there is no need of estrogen. So we are not adding any estrogen. It was not effective. When we talked about the prednisolone, I think so, it is only effective in the recurrent pregnancy loss, though the data is still not proven. But we are on that to producing certain data on the recurrent pregnancy loss and prednisolone. As far as concerned the ecosprin, that means aspirin, we are still saying that data is not confirmed, but we are still using in the advanced age. And if the patient is having a certain thrombopathies, and third thing, where we are having a recurrent pregnancy loss. So rest of the other thing where ecosprin is not effective. And last part is luteal phase supporting RPL. So before we start about the HRT cycle, there will be history of luteal phase supporting RPL. And this is a first study of Promise et al. And Kumar et al. The Kumar et al., which was published by our own Dr. Sudha Prasad and the Ashok Kumar, those who say something is vaginal progesterone and dydrogesterone, which is effective. And let's say something about here, Kumar et al. And they said that when you give vaginal progesterone and dydrogesterone, the dydrogesterone will reduce miscarriage rate 2.4 times higher in the placebo versus dydrogesterone group. So when you give placebo versus dydrogesterone, there will be more abortion. But when we give, it's about the micronized vaginal progesterone, it is not effective. Placebo versus micronized vaginal progesterone, it is not effect on the miscarriage. So it is improving, it is as the rate of the miscarriage will be the same. So there is a role of dydrogesterone, and looking to that, this is my suggestion of stimulated cycle. We are not using an natural cycle in IUI, not required in CC-induced cycle is not required. Gonadotropin we are using as good as whatever your stimulation, but we are using always as good as IVF. And stimulated, we have a 3 paradigm. One is the paradigm of micronized vaginal progesterone, gel, OD. We are using gel OD, or there will be shifting toward the dydrogesterone 1 TDS or PASRI. There will be 200 milligram TDS or 300 or 400 milligram PASRI BD. In FET, let's say something now, review on the FET. So freeze embryo transfer. So why we think about the frozen embryo transfer? I think so, the last tertiary, there is a clear message. And I think so, a lot of speakers, even though the Matthew Rock et al. Study, there are a lot of speakers, they are always want to speak that you want to land the plane, but you don't know what is the exact size of the runway. And sometimes it will lead to make accidents. So if you are dealing with the more accidents and you are dealing with the less pregnancy rates, there is one publication that in the phase cycle, the IVF cycles, whatever the IVF cycle, you cannot give more than 20 to 25% success. That is what we are feeling in India. And looking to that, we all people are interested in 2 things. One thing is, yes, we want to free the complication-free IVF treatment. And second, we want to increase the IVF success. But when we talk about the complication in IVF, it's OHSS. And this freeze-all is moving toward the OHSS-free clinic. And how the success rate will improve, that we decide by these studies. And it is not because that we are talking about the freezing cycle. The need of today's is always because of the industry moving toward the slow freezing with the fast freezing technique, which is called vitrification. And I think so the Vienna consensus and alpha consensus, they say that consecutively, that follow the benchmark. Their benchmark is 95% or more. So when we freeze, and I think so, on freezing and thawing, you should be always reach around 98 to 99%. That should be your benchmark. So we are always having in my clinic, if I say something, my freeze thaw embryo transfers and the loss ratio is always below 2%. And that is what we are doing freeze all since 2014, where people are still fighting and debating. I used to say that it's not to debate. It also to conclude your clino-embryological excellency. If you are more excellent, then forget about the publications. You can shift your practice and give more results. And this is what about the phase cycle. I used to always find out the studies which is going something which is showing something ambiguity regarding the phase cycle. If you see the meta-analysis, they are always showing that 45% results in phase cycle. But look at this ambiguity in the European study in ASHRAE 2013 registry. There is a lot of ambiguity between the phase cycle transfer. In Iceland, it is 18.9%. In Lithuania, it is 14.8%. The average phase cycle transfer success rate is not 32. I still want to say that it is 20 to 22%. And that is, this is a one study which was criticized by Matthew Rock because it was retrospective, because it was on the more younger group of the patient, because it was 65% patients are PCOS patients. And that's why, if you see something here, more the oocyte, more the freezing. If you ask me, when you are having a more than 25 oocyte, and if you have a most freezing and consecutive cumulative live birth rate, maybe reach around 70 to 80%. So, which was criticized, and still there is a publication which was still there. There is no any publications in the favor of freeze all. And let me tell you, there are 2 communities are still standing. and always having a bias regarding fresh cycle and frozen cycle. I say that this is the 2018 to November. They said that normal responder and poor responder still required no freeze all. And hyper responder, there is a clear evidence that freeze all. But there are industry, the industry like the organization like us, where we do have a patient's demography is different. We have a more PGTA program. We have more OHSS patients, like PCOS patients. We are having a elevated progesterone or maybe a day 6 blastocyst. We can observe something. We have a time-lapse technology, so we know that what is a lagging blastocyst, and a lot of other indications of uterine pathology, then random start ovarian stimulations. And I think so there is one evidence which is coming out that though it is not confirmed, I still not say that in recurrent implantation failure. And also, even though evidence is lacking, I still not favor that. Yes, I will always go by the thin endometrium and the grade 3 or grade 2, grade 3 endometriosis. So if you ask me that this is the thing and today is the demand of patients and all this looking to that, I think so 80 to 90% industry are shifted toward the freeze all or freeze more, right? I still not believe that freeze FET cycles are giving more hypertensions, and I still not believe that FET cycle do have a large for gestational age. So we are doing since 10 years. We don't have any experience of large for gestational age. And I don't want to publish any paper which is in the favor of the small for or the exact gestational age of baby. Now, this is the SWOT analysis, that why freeze all is still in the debate and why people are afraid to say on the platform that no freeze all. It's all about the weakness, and the weakness is the study. The publications are very small in the support. But then I say something, which publication which is in favor of ICSI, and which publication is favor in antagonist protocol, and which publication is more in favor of day 5. So this is all about the train. It's all about the clino-embryological excellency. It is all about the certain learning curve which is required for the freeze-all excellency. So I still believe that don't shift yourself on freeze-all immediately. I always say that if you are riding a bicycle, you cannot immediately ride up aeroplane. So freeze-all, it's all depending upon that how your team is optimized. It is not about the shifting immediately. It is all about the optimizations of team. And if your freeze-throw ratio is good, if your demography is demanding regarding the affording all the cost which is involved, then yes, the freeze-all is always good. We are always shifted toward the freeze-all. The conclusion was the freeze-all. I always say the day 3, day 5 is not a debate. If people are saying that I am transferring day 3, so I am a smart doctor, and I am not transferring on day 5, or the day 5 doctors are poor or something like that. The freeze-all are non-scientific and the fresh are scientific. These all things, I think so we have to conclude by a certain conclusion for a freeze-all. I think so for the freeze-all, it's better that if you don't have a freeze-all success rate which are higher than fresh, don't shift. So it's all about the excellency in the embryology team. And if you are having a good excellency, yes, I think so freeze more on freeze-all, which is the demand of the today's demography. Now, let me tell you something how we can prepare the FET HRT cycle. And this is a beautiful observations which was I'm making on the schematic diagram, that we have a 4 type of cycle where we can prepare the endometrium. One is natural cycle, the modified natural cycle, the stimulated cycle, and artificial cycle. I know that now there are a lot of evidence are coming toward the natural cycles and modified natural cycle. Still, people are not shifted toward the from artificial cycle to the natural and modified. I will tell you that where I am. But at present, I know that we are more on the artificial cycle based on the other conditions where we are doing natural and modified that I will discuss in the next slide. Now, let's say something about we are preparing the lining, we are preparing the endometrial thickness, and where we need to supplement estrogen. So estrogen supplements, what are the facts? How much time you can give estrogens? What are the time? And it's very clear that you can always give 12 to 14 days. So don't call the patient in between. I've seen something, a lot of specialists, they are calling on the 8th day. Then again, after 2 days, there is no requirement. Call the patients on 12th or 14th day of the estradiol valrate. Other part is that what is exactly how long you can give. If I can give for 21 days, 31 days, but practically I can say that not more than 20 days. Whatever this publication which was published, it is leupride down regulations. So if you down regulated by a leupride, then might you can do something 31 days, but still I will not go by any unphysiological rather than physiological. I will always balance and I will always transfer his two embryo on around 17 to 21st day of the menstrual cycle. So this is what about the 14 days. This is what about the at what time you can have a call the patient. This is what about the which estrogen you are using in India. It is two salts are available. One is estradiol valrate and second is estradiol hemihydrate. I still believe that new is welcome, but I still not say that it is replaceable. I believe that still estradiol valrate is getting the same result with the estradiol hemihydrate. So time will say, and we have our own observational data. We say that the thickness and everything will be the same as whether you're using hemihydrate or the valrate. Now, as far as concerned the estradiol valrate, that should we give step-up protocol? It's all about our psychological the concern. I don't think so that if you give 1 BD or 1 TDS, or if you give a different protocol, I don't think so that it will it will affect on the live birth. But I think that, yes, we are physiological. And we are a doctor, especially I am a doctor like that. I want to follow the physiology. So we will always go by the step up by 1 BD, 2 BD or 1 BD, 1 TDS, no matter what you are using. But exactly that, what will be the highest dose? Then the highest dose is not more than 12 milligram, 4 milligram TDS. And I still say that I've seen doctors, those who are doing some vaginal, there are some doing transdermal, and they are also getting the patients. And they are always discussing like that it is not sufficient and it is effective in the refractile endometrium. I still not believe. I say 12 milligram is enough. There is no need of, there is no second route is required. And getting the two routes applications which never have any advantage over the one route. One thing is that the optimum endometrium is always more than 9 mm. The lowest normal value where pregnancy was observed frequently, it is 7 mm. Now, how to prepare the endometrium? So this is about the natural cycle. Now, what I want to say in the natural cycle and modified natural cycle, in both that, in natural cycle is very tedious. I think so. It's not made for Indian populations to measure the luteal phase, the LH kit. And if it is not controlled or not going to be observed, so maybe possible in natural cycle by the lab, you can call the patient for sonography. And whenever that the follicle, which is reaching around more than 16 mm, I think so, it's not something about the more maturity. So I will like to say something around 16 to 18 in natural cycle. But when I go by the stimulation, I will always give what 16, 17 mm. I will give the SCG trigger, and post SCG plus 6 or post SCG 7, we can transfer the blastocyst. And let me tell you something about that. The more data still required. but it will reduce the pregnancy loss compared to the HRT. And that is why I was shifted my HRT program specifically in the refractile endometrium at present, when there is a previous failed and I do have a more embryo. And second thing that I shifted my modified natural protocol where exogenous estrogens are producing any side effect. There will be a thrombopathies. I do have 2-3 patients running in this month also. So we are using natural cycle, specifically and is indicated. Still, we are 98-99%. We are shifted toward the HRT cycle. Now, what about the down regulations? And this is again the debate. So I think so. There is no data still confirming that Cochrane data review still not confirmed that the down regulation is really helpful or not. So jury is still saying that it is not harmful. The people, those who are comfortable, they can down regulate. But then what will be the patient friendly? Are you using an agonist or antagonist? So you have a patient friendly that you can use antagonist where agonist was used previously. And that is what I'm using antagonist, that I'm using antagonist of first 5 days of the menstrual cycle of day 2 to day 7. And that will create a immediate decrease FSH and LH. And associate with, I can give a 2 milligram tablet of estradiol value. This is a study that say that more patient friendly than no injections. I believe it's a future that when the study will come, I believe that only estrogen is required. I know that the 80% patients are still not down regulating in India also. So it's all about the matter. I still not a rigid on not using any down regulation. The jury is still out to decide whether what to do. And at the end of the day, we can say that no down regulation, which will be the most publications are there. Now, what about the type of the estrogen and what about the type of the cycle? So there is no superior. So all are equal. But now the new data which saying that natural cycle and modified natural cycle, especially natural cycle, it is a more physiological and less abortion rate which was observed. But time will tell. Our experience, it is not time to shift by looking to all evidence like that. We are shifting to looking to other evidence and then we will have a go to back. So at present, I think so still in IVF, we all people are using HRT cycle. Now, if we do HRT cycle, what is non-physiological? That is absent of corpus luteum. So we need estrogen and progesterone both. And what will be the effects of progesterone? We already discussed the micronized vaginal progesterone. It is a supportive, it is a maintenance hormone. The different which was accepted out of that, the micronized vaginal progesterone, which were more accepted, more patient friendly. And that's why it is again will be a choice of treatment. But then let's say something about that. What are the 4 hormones? That it may be a micronized vaginal, it may be a dydrogesterone, we have option, and it may be an intramuscular progesterone, and it may be oral micronized progesterone. And the 5th option, which are still that those who are using injections, it may be a subcutaneous injections will be there. So out of this 5th option, what is better? And if you ask me that which progesterone is ideal and what is the evidence, let me tell you before to start, I will like to agree that before to start this slides of freeze embryo transfer, I am a strong believer of injectable progesterone. But let me conclude and confess that I completed my study in the freeze embryo transfer and we concluded that it is equally effective. So we shifted toward the micronized vaginal progesterone. Now let's say something before that. I would like to say that what are the options, and the options are intramuscular progesterone, the oral dydrogesterone, and vaginal formulations. These are the dose which was saying on the slide. So when to start progesterone, and why we can synchronize the embryo, is it synchronization will helpful? So if we have a 5 days progesterone, 5 days embryo, then we need to give 6 days of the progesterone. It is called synchronization. That is what published in 2016, 2010, and 2005. And which was tested by the different study. Let's give one more day's progesterone and let's start something 1 day late, and let's give something 2 days more. So 2 days earlier and 2 days more. These all things are showing more abortions compared to the synchronization. So by this study, we can say something, we can start the progesterone after the estradiol valrate when the endometrium is prepared, and the day where we can start the progesterone here, it is considered as P+0. So when I talk about the P, then we can say P+5. So it is all around 6 days of the progesterone when we are giving to the patient. It is a 6 day of the progesterone. Now, if you are doing a natural cycle, what will be the evidence? If natural cycle, then corpus luteum is there, or in the stimulated cycle is corpus, so modified natural cycle, this corpus luteum is there. Would you like to give progesterone? And the answer is yes. And this is the study. What they say that progesterone supplementation is improve the live birth in embryo transfers in natural cycle. Now, when we say something about the evidence, what is evidence? That we started in the stimulated cycle a single gel a day or micronized vaginal progesterone 2 times. So people are starting that. Let's say something about people are started a single time gel. So I do have a lot of question that when we have a corpus luteum, still we have a 1 day progesterone, single time or the same dose. And then what exactly we are on the right pace or not? And I started in my own clinic a 2-time vaginal when I'm not using injectable. So 2-time vaginal. And this is my journey where the publication, which was published later on in 2006 to 2011, that adding more vaginal gel, which improves the live birth rate. So I think so, doubling of the vaginal gel. So those people are using the gel. At present, they are using 2 times a day in a frozen throat transfers. Now, these are all retrospective data that what is useful, either a combination or either gel only or either injectable. What is exactly evidence? And this is what the evidence, which was retrospective data, the duration of the study from 2010, 1 January to 2012. And the study was conducted on 682 patients on IM progesterone, on only 238 on gel, 8%. And the conclusion was very clear that both are equally effective. So this is the first study which was favored in the gel BD by Shapiro et al. In 2010, especially in the freeze all or maybe freeze embryo transfer the HRT cycle. Later on, there is another huge retrospective study, which is autologous and donor oocyte blastocyst cryopreserve. This is the 2 previous studies, Shapiro et al. It is also donor transfer, but it was 2 blastocyst transfer. So they say it was 2 blastocyst transfer, it is a bias. What about the 1 blastocyst transfer? And here the study, which was published in 2014, the retrospective study, 5 years data, that 50 milligram injectable progesterone and the vaginal gel. But the vaginal gel is only 116 patients and the injectable progesterone is 1594 patients. And the gel was given 2 times as compared to the progesterone. And it was still clear that gel is equally effective of the injectable progesterone. So this is what only one randomized controlled trial, prospective randomized controlled trial, which is gel once a daily, gel twice daily, and progesterone intramuscular. the randomized controlled trial of around 135 patients each, and progesterone vaginal gel can be useful, successfully alternative to intramuscular progesterone. So again, these are the evidence which is favored in the gel study. But what about the combination? And this is what about the combination, that what exactly we can add. And as still there is a debate that dydrogesterone alone is not effective. People are not using alone, they are adding alone on the injectable and also on the dydrogesterone, adding on the vaginal gel. And this is the study of comparison of injectable and dydrogesterone and vaginal gel and dydrogesterone. The vaginal gel progesterone supplementation has good effect on frozen throat embryo transfers and can significantly increase the rate of implantations, abortions, reducing the abortions compared with the intramuscular injections. Later on, there is a single center study about the Shanghai, September 2010, January 2013. Here the bias is day 3 embryo transfer. Here the gel, PD, and they do have a 40 milligram injection, and there will be a dydrogesterone which was given a 20 milligram a day. Now, all the study, there is a heterogeneity of the using of the doses of the hormone, maybe gel, OD, BD. There is no particular things which was given. Also, the injections are also using something about 25, 40, 60, 80, somebody's 100. So this is the data. That's why, and there is also heterogeneity in the number. Always all the retrospective data, the injection data is higher compared to the gel data. So this is all the debate. That's why Cochrane data is not that much of comfortable, that still it is not clear that what is superior. And what about the dydrogesterone? This is one about the Asian Pacific Journal Reproductions. It is saying something, it is effective, but pilot study which was published, it was says that 9%. So dydrogesterone alone is not effective. And that's why you cannot use without the use data of dydrogesterone specifically alone in the HRT cycle. So what about the debates? Debates still continue. And those who are believing in injectable, they are explaining in such a way that they are continuously delivering the progesterone. And that's why the peak and less peak value will be less, the constant release, and the serum progesterone is more achieved compared to the vaginal. And they are saying that vaginal progesterone, yes, it is independent, especially there is a less uterine quiescence effect because the high dose deliverable of the progesterone through vagina and less liver bypass effect. So they say that more advanced endometrium, more contraction, less quiescence, less serum progesterone. Now looks very interesting, but the thing is that then we need some study, and this is the study which was published in the favor of injectable, that is the retrospective data, and it is day 3 transfers. And look at the progesterone which was given, which is 8% gel twice. But if you say something injectable, then it's only 25 to 50. So they never mention something exact dose. But here, the data is saying that even though twice gel, they said injectable progesterone is having a higher success rate. But here, the bias is day 3. Here, the bias is day 3. And that's why they said there should be some publications on day 5. So this is one publications of the Katie Devine et al., the 3 groups, retrospective data. And one group is having a 200 milligram endometrium. Now here, again, they give twice daily. I said, why you are everywhere is giving twice daily? Here they produce again a bias of twice daily. And if you see the vaginal progesterone, they started on the day 1, then 3, then 5, then 7, then 9, or they can give only injectable progesterone. The study is saying that the A group and B group, which is injectable, look at the ongoing pregnancy rate, which was 15% higher. look something more promising in the two, but both are retrospective. Here it's day 5. Here it's 200 milligram only BD. So still not concluded. Data is still confusing. And still we require the huge data. Now our study is in pipeline, and our study, and I know the results. I'm not showing the data, but it is a huge study that what we are publishing. More than 250 patients is on vaginal, and we are using vaginal gel and dydrogesterone 1 TDS 10 milligram versus injectable progesterone. All are 2 embryo transfers, and we are choosing more genetically tested embryo, and we found out that the equal pregnancy rates are there. But we have a certain effect that if there is bleeding when we are giving vaginal progesterone, in that patients, we can give injectable progesterone in the next cycle to get the sustainable pregnancy. Now, this is what about the subcutaneous progesterone. So I'm not going to say something that it is not effective, because I am now shifted my practice to injectable to vaginal. So now I'm doing almost 120 transfers a month, which was all vaginal. I am comfortable getting the same results. And I think so. My study is more advantage that all blastocysts are genetically tested. So I think so. The people, those who are confused because the generation, the pain is concerned. I do believe that when I am doing this, I always concerned with the pain. And that is what I took a step that let's move ahead. And at present, I do believe that vaginal and dydrogesterone combination. So we are all cycle now vaginal gel BD and dydrogesterone 1 TDS. I don't know that if giving a dydrogesterone BD or TDS, I don't know whether it is how it is effective. Then I need one more study without dydrogesterone. So at present, I'm adding dydrogesterone because we can see that 9% success rate is achieved. So anything you are giving, but yes, I'm sure that after getting the pregnancy, we are definitely giving and continuing the dydrogesterone till 12 weeks of the pregnancy for the reducing abortions and bleeding problem. So we are at present injection free, or we can say that we are not using injection until and even patient is having a bleeding. If there is injectable, I still believe that the subcutaneous injection is better rather than the IM injections. It is less painful. Now, what about the luteal phase support by the trigger method? We haven't discussed in the previously that if you have a trigger on SCG, if you have a GnRH agonist trigger. Let me tell you, before you shift your trigger, I still have a study which is going to be published, and the study is very interesting. SCG only versus SCG plus 2-decapeptide. The results are very clear that these all add-on are not helpful even in the poor responders. I still believe that SCG alone is effective, but I still not believe in GnRH agonist alone. But that I believe in GnRH agonist specifically in the PCOS patient, but then I don't believe in the phase cycle transfer, so I don't require luteal phase support. And this is the study of Imidian, interesting study of the miscarriage rate that on the GnRH agonist trigger in the PCOS patient, that is a 79% miscarriage rate, which was reducing by adding SCG bolus of 1,500 IU plus the normal progesterone. So if you do normal progesterone plus SCG bolus of 1,500 in India, 2,000 IU is available, then it will be prevent the miscarriage. Again that if you have a modified luteal phase support versus SCG trigger plus conventional, then in the phase cycle, there will be no clinical significance. But I am not interested because there will be a chance of OHSS. It's very thin line. So we all shifted toward the freeze-all. I think so. We are still not much more happy with this all evidence where we are not transferring the same cycle. So at the end of the day, the Cochrane evidence instead of the study, which was, I think so, there are a lot of studies now coming for the vaginal and the injectable. And I'm sure that according to my study observation, and I'm sure those people you are using injectable, I will like to say them that I'm also one day that I'm using only injectable. The change which was I observed and I shifted myself by my observations and my study. I always believe that do your work, publish your work, or not publish, but at least see your work, and you can understand that what is better. Don't blindly follow the publications. So still the jury is out. We don't know what is the exact, whether it is injectable or whether it is that. So what is my conclusion? The conclusion is very clear. The conclusion that in the previously, the thoughts at my place is injectable, which was shifted. The answer is very clear that we are shifted toward the gel PD and dihydrogesterone 1-TDS. If the people will ask that, is gel is going to do something? I said, no. You can use PASRI also the same with dihydrogesterone 1-TDS. So the answer of this luteal phase is very clear that in injectable, in a phase cycle transfer, so in IUI, you need luteal phase support, what you are using in IVF cycle. In a phase cycle transfer, the conclusion is the paradigm from SCG to shifted toward micronized vaginal progesterone, gel OD, 400 milligram BD, and dihydrogesterone paradigm from 1-TDS. And in a frozen embryo transfer, the paradigm for injectable, I think so there is a time to move on from painful to painless, where we are 90%, 100% resolved to reduce the pain of the patient with the same result. I think so progesterone gel and dihydrogesterone 1-TDS is equally effective. And when you have a problem, when you have a recurrent implantation failure on the same progesterone, or you have a bleeding in the previous cycle, you can use alternative progesterone, which might be helpful. So that is what I'm doing. Thank you so much for hearing a luteal phase support. I feel that I consider that the message was very clear to you. If you have any question, then you can give me or you can give a chat board or give it to the MOC of the whole conclave. Thank you so much.
Thank you, sir. Thank you so much for a wonderful session. And I'm sure everybody will be helped. And it was a very, and indeed a great learning session. All the doubts have been cleared regarding stimulated cycles, IVF cycles, when to start, when to stop, dihydrogesterone, estrogen. Everything has been very well covered, sir. Thank you so much. And I think, are there any questions in the chat box if we can take right now, or we'll be taking it later, Mehulji?
I think so. We can take later.
We can take it later, sir.
Later.
Yes,
And
sir.
next. I want to announce that those who are here, I will soonerly going to publish that our Wings Fertility Conclave now going to give you and the knowledge or on the global platform, and that is Wings World Fertility Conclave. And we have a 3 interesting subject on that, and which is more important, where a very renowned speaker. So these are the three interesting subject. I think so. One is regeneration and rejuvenations. The mentor of the world of the regeneration and rejuvenations will going to speak. I will not announce the name, but he will going to speak on regeneration and rejuvenations. And the second is male infertility, and where Dr. Sandro Esteves will give the talk on the specifically azoospermia and the medical management of the male infertility. And the third speaker, where we all are talking about the non-invasive PGS. And we are always saying that I am a PGS or pro-PGS doctor. In the indicated cases, there will be a lecture of Dr. Carmen Rubio, who is she telling about the PGTA and non-invasive PGS. So the date was decided. I think so sooner we will give the dates. It's all about webinar. So you can hear and get and share the knowledge at your home. Thank you so much and good night to all.
Good night, sir.
Thank you, sir.